The voice, John H. Remington of the University of Rochester School of Medicine, moderator for this fast-paced edition of Audio Digest Surgery, Volume 18, Number 9, Carcinoma of the Proximal and Mid-Rectum, the choice of operative procedures.
Just what is the mid-rectum and what's the proximal rectum, I don't know. Everyone has a different idea. For the purpose of our consideration, we'll say that the rectum is about 18 centimeters long, dividing it into 6 centimeter segments. We'll disregard lower 6 centimeters. So we have the upper 12 centimeters above that 6 to consider.
The choice of operative procedures includes anastomosis, the pull-through operation, combined abdominal perineal resection, and local treatment, excision or fulguration. Joining Dr. Remington in comparing surgical approaches are Willard H. Bernhoft of the State University of New York School of Medicine, Guy L. Kratzer of Allentown Hospital in Allentown, Pennsylvania, and Charles B. Ripstein of the Brookdale Hospital Center in Brooklyn, New York. During the next 60 minutes, you'll hear these guest surgeons discuss the indications, advantages and disadvantages, and techniques of the various operative procedures available for both the curative and palliative treatment of carcinoma of the rectum. Then outline the prevention and management of the numerous complications that occur in the treatment of rectal carcinoma. And now to begin, here again is Dr. John H. Remington.
Charles, given a patient with a carcinoma within this area from 6 to 18 centimeters, what factors would influence you in determining whether you would do anastomosis, whether you do a pull-through, or whether you do a combined abdominal perineal resection?
Could I add one more choice to that, John, whether I might choose to treat it locally, either by excision or fulguration?
Surely.
Because I think that this is the area where all of these choices may enter into the decision. We have to consider 2 factors. First of all, the tumor itself, and secondly, the patient. The first aim, under any circumstances, has to be to cure the cancer. But this can be a delusion if, for instance, you're dealing with an elderly individual in whom liver metastases have been established or metastases elsewhere. And here our aim surgically is to give palliation from local symptoms, because we're not going to cure the individual. I think it makes a great deal of difference whether we're dealing with a young and vigorous individual whose prospect for long life is good, or with someone either in an older age group or suffering from other diseases which may give a very poor prognosis for future longevity. And these are the factors that influence us. In addition, things like obesity, the sex in terms of creating technical difficulties for resection and anastomosis may all be factors that will play a part. So that we have a variety of possibilities. My own feeling is that the abdominal perineal resection, the Miles operation, which implies a permanent colostomy, is an operation that should be perhaps the procedure of choice in the younger and good risk individual in whom you want the very best chances of cure. On the other hand, any lesion at 6 centimeters is usually amenable to either pull-through or to anterior resection with or without a diverting colostomy as a temporary measure. And certainly, especially in the older age group, people who are afflicted with Parkinson's disease or other such things which make it difficult to manage a colostomy, giving them a functioning anus is, I think, something that we ought to strive to do. And finally, in the old age group, patients in their 80s and 90s, we have had very good luck with local treatment, especially for tumors that arise on the posterior wall of the rectum. And I think that there is really a place for this. I can't accept John Madden's dictum that this is the procedure of choice. I don't think it is at all, but we have found that the vast majority of this older age group will outlive their tumor and will not die from the effects of the carcinoma, but from other factors before the tumor has a chance to recur or before metastases become widespread. So that I think particularly in this group, the local treatment is the treatment of choice. And sometimes it's thrust on us. Recently, I've had the experience of treating the wife of a doctor in her mid-40s who categorically refused to have an abdominal perineal, who had a lesion that was not very amenable to anterior resection and which is now gone for 4.5 years and still without any evidence of recurrence after local fulguration. This, of course, I'm sure we've all seen, but percentage-wise, it's not the ideal choice. So I can't lay down any definite rules except to say that all these choices are available, and these are the factors that might decide the operation to be done in any individual case.
You disagree with that, Bill, at all?
I'm in complete agreement. I might add one point that I think is important as to arriving at a decision as to what procedure, and that is perhaps where the lesion lies in relation to the peritoneal reflection. The peritoneal reflection varies in every individual. Sometimes there's a very deep pelvis. The lesion may be mid-rectum, for example, and still be above the peritoneal reflection. That could very well be a factor in determining my choice of operation.
Guy, we've mentioned John Madden, New York, and what he's advocating. What do you think of this fulguration business? Have you done much of it?
No, I haven't done a great deal of fulguration, but I'm very, very much interested in fulguration because one cannot help but be interested in the results that John Madden has reported and Jackman of the Mayo Clinic.
What are Jackman's statistics?
Jackman's figures, and I think Jackman is frequently misquoted. He selected a group of patients where the treatment in that particular case was equivocal. He selected patients with sessile lesions 2 cm in diameter or greater than that, lesions that were not ulcerated or not clinical carcinomas, although the microscopic report showed any variation from carcinoma in situ or adenoma with adenocarcinoma degeneration grade 1 up to grade 3. These were selected cases. I might mention here that I've been very much interested in this work. I jotted a few figures down here. He had 252 patients, all sessile lesions, and where conservative treatment was recommended. They divided these 211. The treatment was given, conservative treatment, and carried out. There were only 8 failures. 3 were partial failures where after fulguration they had to do Miles resections. 5 were complete failures because they all died, although they had subsequent Miles resections. Group 2 patients, there were 41 where they recommended conservative treatment, but the surgeon who saw the patient decided to do a resection. And in reviewing the pathologic specimens after resection, they found that 40 could have been managed conservatively. There was 1 failure. This was a type C. So that is interesting. Of course, Madden took 28 cases of carcinoma. He found 2 out of 3 were alive 4 years afterwards, which I thought was rather good.
In Jackman's statistics, in this selected group, the risk of operation, as I recall, was thought to be greater than the risk of letting the carcinoma stay there or doing something conservative. Isn't that right?
That's right.
And I think that is the thing, whether the patient has a greater chance of dying from the carcinoma or from the operation. And I think in the older age group, with some of the complications is often greater, of course, with the operation. Now, what about these technical difficulties, Guy? What about exposure? Do you do it in your office? You do it in the operating room? You do it at one sitting? What do you do?
Well, Madden, of course, describes where he removes the lesion under spinal anesthesia in the hospital and uses either lithotomy position or jackknife position, depending on whether it's anterior or posterior in the rectum.
Does he do it all at once?
He tries to do the entire procedure at one time. He'll fulgurate a layer, and then he'll scrape this off. And if he sees this material remaining, which he thinks is carcinoma, he does another fulguration and scraping until he gets down to soft base.
How often does he have to do it at several sittings, did he say?
Well, the average number of sittings is about 3 sittings. He has done some in just 1, and others take 8 or 12 sittings.
What about exposure? Does he split the muscle?
No, he uses EVA retractors and similar retractors to get...
Charles, you've done this. What technical difficulties have you encountered with exposure?
There are none at all. You just need enough assistance, that's all. And I might point out, too, I've watched John Madden do this procedure many times as well. It may take 3-4 hours with a fairly bulky tumor because just using a needle, you fulgurate a surface layer and then with a sharp curette remove the fulgurated tissue. and keep doing this until, as Guy points out, you get down to a soft, flexible layer. And sometimes on the posterior wall particularly, you go right through into the perirectal fat.
What about on the anterior wall? Got a vagina or bladder up there?
Well, this gives me occasion to pause and think, and I don't use this procedure as a rule on an anterior wall lesion because I'm very much afraid of going into the bladder. Then you control your depth by frozen section, and in about a week the patient is taken back up the operating room and the lesion scraped again and checked pathologically to make sure there's no residual tumor.
What about doing it in your office through a scope?
Oh, no, I don't think that this is an office procedure at all. I think the difficulty of obtaining good exposure would be too great. We have an operating anoscope that's maybe 2.5 to 3 inches in diameter, and you really have to dilate the sphincter up, although we've never had to cut it, to get this exposure. There's many problems. Of course, the most serious is that sometimes these things will slough postoperatively and give rise to bleeding. But again, this can always be controlled.
Well, I disagree with you in one thing, and maybe so I can get some support. I think you can do some of these in your office, and I've done quite a few of them. And I don't try and do the whole thing at once. I char the thing over, have them come back in a week when it's sloughed off, and in several sittings you can do it. And on the anterior wall, with this gradually sloughing off, you don't run the risk of going into the bladder or the vagina. Anybody agree with me? Guy?
Yes, I agree. I do many carcinomas in the office.
Well, let's go on. Now, Charles, what if you open up a fellow and you find he has more metastases than you thought? He's got seeding around the peritoneal cavity and some acidic fluid and a carcinoma of the rectosigmoid. Would you back out, or would you do a colostomy? What would you do?
Well, again, it depends the case, as the French professor would say. Certainly, I think with peritoneal seeding in the pelvis, this is a bad time to do a low anterior resection, because even though you may get away with it without any post-op complications, you're very likely going to find local recurrence, which will produce obstruction before the patient will succumb.
What about a colostomy?
I think in most of these instances, this is a procedure of choice if the patient is partially obstructed or bleeding.
Do you agree with him, Guy?
I certainly do. The rectosigmoid is the narrowest portion.
Colostomy?
I would attempt to get as much of the primary lesion out as I could.
With metastases and seeding and ascites?
I would, and do a colostomy and leave the lower rectal stump.
Well, I think all three of you are wrong. I think you should back out. If the patient has that much and he has no clinical signs of obstruction, I don't think we should do a so-called preventive colostomy, thinking that he might develop obstruction in the future. I think the vast majority of these patients will die before they ever develop an obstruction. The occasional case that does, you can do it terminally and bring out a loop. But I think you do a disservice to the patient and a disservice to his family to do a preventive colostomy. I think a preventive colostomy is an unnecessary colostomy. And I've closed up quite a few of these, as long as they're not having obstructive symptoms. And only one or two ever went on and developed any obstruction. So I think a preventive colostomy is unnecessary. And I think perhaps in thinking to do something, too often we do pull out a loop. Well, I got my point across. Bill, in Buffalo, they're freezing some of these things. What do you think of that?
We're not enthusiastic about it. One of the surgeons at the Veterans Hospital has the unit. We have called him into our hospital to do a number of cases, elderly people which were nearly obstructed. We knew our lesion was inoperable as far as any attempted resection was concerned. We felt that we could obviate obstruction and carry this patient along palliatively.
Was it any better than fulguration?
I do not think so. And we did run into a problem in 2 cases in which we had massive hemorrhage, which was really exciting and frustrating. And actually, we have given it up.
Charles, have you had any experience?
Yeah, we've tried this. I think if you have a $10,000 cryotherapy outfit, you have to use it for something. But we've given it up because fulguration is much safer and the incidence of post-operative bleeding is much, much less. We ran into exactly the same difficulty as you did, Bill. And I don't see why there's any real advantage in this, and especially because you get a terrible slough, which you have no way of controlling. At least with the fulguration, the slough comes off at the time, and there's relatively a narrow layer of necrotic tissue that forms later. You can control this, but with the freezing technique, it's very difficult to control the depth of slough and a tremendous hyperemia and reaction that follows thawing out of the lesion, and we've given it up.
While we're on this subject of less than resection, Charles, a couple weeks ago, a surgeon friend of yours in Rochester sent me a 78-year-old man with a 2-centimeter carcinoma on the posterior wall at 8 centimeters, and I recommended fulgurating this in the office. It was small. And he talked to a radiotherapist at the university, and they decided on cobalt. What do you think of that?
No, I think that the point was made the other day that cobalt or any kind of radiation therapy is effective in carcinoma of the rectum, and this is true up to a point, but I don't think it's the method of choice. If you're lucky enough to find a lymphosarcoma, then it'll melt away. But
to me, this would have been ideal. Right in the posterior wall, you could have burned it right down. But
it's so simple to do, and the only thing I differ from you is that I wouldn't want to do it in the office, but I don't like doing anything in the office, and I would feel, though, that fulguration would be the treatment of choice.
With this, I could have done it in 3 treatments in the office, very simply. Now, one other thing here. This thing came up in a panel in Minneapolis a couple years ago, and I had a set to with Martin Black. He thought you should put radium in there. Don't you think that's wrong, too? Charlie?
Yes, I do, but I must say that this comes from a vast inexperience with the use of radium in the rectum. But I think fulguration is the answer to this problem.
Bill, you have anything to say about radium?
I have not used it, and I have no reason to use it because I believe fulguration is the procedure of choice.
Okay. Bill, you've published your technique of the pull-through operation. Would you describe it here briefly?
The abdominal phase is carried out exactly as though we were going to do a combined abdominal perineal resection or a low anterior resection. We may not have made up our mind at the beginning of the procedure as to which operation we were going to use. We were careful, however, to preserve the blood supply by way of the marginal vessels so that the mesentery was fenestrated initially well below the marginal vessel. Assuming that the lesion was located at an area or a level, would ordinarily wish to do a low anterior resection, but there were technical difficulties, narrow pelvis or what have you, which prevented a low anterior. Heretofore, we may have gone on to do a combined abdominal perineal resection in light of our inability to technically do a low anterior. We do not feel that that is necessary. We do not think that it would be necessary to jeopardize the sphincter mechanism. Therefore, the abdominal phase is completed. We have inserted a 38 Pisar catheter into the segment of bowel that we're going to pull through. The first assistant drops out away from the abdominal phase of the procedure and goes below. The operator slides the Pisar catheter through the rectal segment. The assistant puts gentle traction upon the catheter until it is well out of the anal orifice. 2 things need to be watched for. First, that the marginal vessel is not under traction over the brim of the pelvis. With the procedure carried out under direct vision of the surgeon, that can be watched for. One point that I do wish to make, regardless of how much we try, when the catheter has pulled through by the first assistant, the bowel will rotate. In other words, we've watched it under direct vision. The tenial band will rotate over, and I think that that may be a factor in some of the complications that have developed with pull-through procedures where it has not been carried out under direct vision.
In other words, you don't want any torsion on that at all?
That's right. Now, the pull-through segment undergoing maturation exactly the same as a colostomy undergoes maturation on the abdominal wall. This is no different. The segment develops a serositis the same as it does on the abdominal wall and gradually contracts as it does upon the abdominal wall. We do not find it necessary to do any revision at all. It will retract spontaneously, and by the time a retraction has taken place, there is good adherence of the rectal cuff to the colon. We do not wish to do small operations for small lesions or big operations for big lesions. And this procedure that I just described is not in any way to take the place of a combined abdominal perineal resection.
For those of you that might want a little more information on this, Bill published this in the Archives of Surgery in '65 if you want to look it up. It's a good article. Now, this is a modification of the old hook and egg. I remember doing some of these in my training, and Donald Balfour revived some of this, and some of the patients we saw then had stenosis of that thing. You put your finger in the rectum and it felt like a cervix. Have you had any trouble with that, Bill? Stenosis. And what did you do?
I'm glad you asked that question. I did not go into any detail of this procedure, but we found it imperative to do routine cecostomies on these patients because this does narrow the same as you get narrowing with an abdominal colostomy. It needs to be dilated, and we found without a cecostomy the extra edema that may develop that we will get obstruction. But a cecostomy is all that is necessary, and we do that at the time that we carry out the abdominal procedure. And then with digital dilations, the same as we dilate abdominal colostomy, until maturation is complete.
What about continence?
We have had no problem that way. It has been found years back that it is necessary to preserve somewhere between 1 and 7 centimeters of low rectal cuff.
1 centimeter, you have continence with 1?
Between 1 and 7 centimeters. That is from work by Gaston back several years ago in determining the innervation of the lower rectal segment, which has to do with the urge to defecate. However, we have found that if we could leave 3 or 4 centimeters of rectal cuff, that was sufficient. I've had no problems with incontinence at all.
Charlie, what about your experience with pull-through, this technique or any technique?
Well, we've used the technique described by Rupert Turnbull in the past, but I've more or less given it up. I've found for the past 8 or 9 years since I've been using a side-to-end anastomosis, side of the sigmoid to the end of the rectal stump or rectal ampulla, that I can do that anastomosis very much lower with great technical ease and with a complete absence of stricturing, and this has been a very, very satisfactory solution to it. Occasionally, in a very obese patient with a narrow pelvis, you just can't do anything, and pull-through is the only procedure, but I've done very few of them in recent years.
You don't do end-to-end anymore, you do more the end-to-side, right?
For the very low anastomosis, I think cecostomy is useless. I don't think it diverts the fecal stream, and it hardly relieves any obstruction at all, and I think if you need a diversion, that a transverse colostomy is a much better choice of procedure. I don't do cecostomy except where the cecum itself is tremendously distended and maybe with serosal cracks or gangrenous looking spots for acute obstruction. There I think a transverse colostomy can still give rise to cecal perforation, and cecostomy or a cecal colostomy is a procedure of choice. But to relieve strain on an anastomosis, I think the only virtue it has is perhaps that Bill sleeps better with it.
Rupert Turnbull does a colostomy in 20% of the cases, he says.
Well, I don't do it anywhere near that. I would say maybe 10% at the most.
Do you irrigate with anything?
Irrigate the bowel itself?
Yes.
Not routinely, no.
At St. Mark's Hospital, Sir Clifford Naughton Morgan says that they've practically eliminated since they've been irrigating with bichloride of mercury solution.
Well, we've gone through chlorpactin, which of course is just Dakin's solution, nothing different. One thing I think that's very important is if you're going to do an anastomosis through any portion of the rectum that does not have a serosal surface, remember that the strength of your suture line lies in the submucous layer, and you have to use through and through stitches if you want them to stay there. You can't use partial layer suturing and expect that it's going to get away. And I think that most of the fistulas that are reported in this area probably come from pelvic collections which break through the suture line. So that I think it's very important to keep the pelvis clean and dry, and we drain them all with suction drainage and irrigate the pelvis with a solution which I don't think has any particular virtue. We use 5 grams of neomycin and 50,000 units of bacitracin to a liter of normal saline and irrigate with this twice daily, and comes out the suction catheter. And that way, if you prevent any accumulations in the pelvis, we've had very little difficulty.
And you use 2 rows of interrupted?
Yeah, what we do is to put in our first layer as horizontal mattress sutures through all layers of fine silk and tie them with the knots inside the lumen of the bowel, and these you put in without tying, so you have the whole row in. And then when you tie those, the posterior wall everts into the wound, and you can approximate again with through and through layers this cuff. And then
both layers are silk?
Yes, silk or teftac.
Some people don't like to use silk down there. They want 2 layers of catgut because of recurrence. What do you think of that?
I haven't so far been convinced that it makes much difference what suture material you use.
What about this iodized catgut cones?
Well, we've gone for that bit, and I've still seen recurrences occur with it. I don't know how valid the idea of recurrences at the suture line are, particularly if you take the precautions that you're all familiar with.
In 100 cases of low anterior resection, what would you think would be a recurrence?
A local recurrence?
Yeah.
Oh, I'd say about 2 or 3%.
Now, do you think, while we're on this, these are suture line recurrences, or do you think that there are recurrences in the pelvis that come through into the suture line?
I think there are recurrences in the pelvis, because I haven't seen one yet that was confined to the suture line.
Well, I think that's been the experience of most of us. Bill, do you drain the pelvis?
I do not.
Guy?
I do in each case.
What do you use? What's our look at?
I use a chafe and drain with suction. Attach it to a Gomco suction.
What's that, a plastic?
It's a rubber drain. They make them plastic. There's a variation on that, too.
Howard Frickman just presented something showing that the rubber tissue drain is deleterious to the anastomosis down there, and we should use polyethylene. What sort of a drain do you use, Charles?
Well, we use plastics. The chafe and drain is made of plastic material. It's an excellent drain. It's a soft drain with a sump arrangement so that you can irrigate through one channel and then put the suction on the other channel, and it works well. Or you can use the Argyle type sump drains. They work well too.
I use the Abramson, as long as you're getting all these names in here. Again, a soft one. Have you used that one?
No, I don't know.
Well, they're all the same. I think somebody has their name on it so they get a royalty. I think that's an excellent idea that you mentioned of putting suction on that drain. You mentioned the breakdown of the anastomosis being from stool leaking through. I think that you're wrong. I think that the breakdown is due to an abscess in the pelvis that breaks into the suture line. You have a perfect setup. You have a warm, moist area with blood and serum down in there, and you always have bacteria. So I think that if you do suck it out and do instill kanamycin or some solution, I've been doing it for 3 years and I've had no breakdown.
I agree with you, John. I didn't say I thought the stool. I think that the pelvic collection is what causes.
And breaks through, yes.
Yeah.
Excuse me, gentlemen, just long enough to signal the end of this side of your program, Doctor. Side B, the continuation of this program on carcinoma of the proximal and mid-rectum, can be heard by just flipping over your recorder's cassette or 2 reels. Continuing a program on carcinoma of the proximal and mid-rectum, choice of operative procedures, this is Side B, Audio Digest Surgery, Volume 18, Number 9. Once again, Program Moderator John Remington.
Now, one other thing here. What about antibiotics? Do you give them preoperatively? I don't mean the preparation of the bowel. If you're going to have a big case, maybe a panhysterectomy and a resection, and you expect it to be messy, or do you give them any preoperative?
No.
Any post-op?
Yes, we do.
Well, I think there again, perhaps you're making an error, because once you get blood clots and serums and little pieces of crust tissue, it's too late, because you need a therapeutic titer of the antibiotic in the blood clot and in the tissue. So I think it's well to give them the antibiotic intramuscularly the night before, during the operation, and then if you don't think you're going to need it, don't give it, but at least start it out during the operation, and then if you do need it, give it for a week post-operatively. Don't you think that's a little better?
I really don't know. I've read so many pro and con articles on this subject that I just don't know what to believe.
Well, if you're going to give it, I think you should give it so you can have the tissues saturated. Bill, do you agree?
When you have a good thing going, you hate to change. I use it, and I agree with you.
Now, here's another thing. What about peritonealization of the pelvic floor? That always comes up while we're on it. Guy, do you peritonealize?
I do. Here recently I've been discontinuing it for no special reason, just because everybody says the peritoneal cavity can handle infection better than the raw pelvic walls, but I have seen no real difference in results.
Charles?
I usually can't because I try to take a pretty wide excision so that it becomes acrobatic stunt to try and get something to cover.
Bill, what do you do?
I peritonealize if I have any peritoneum left.
Okay, fine. That takes care of that. Well, now while we're on this business of antibiotics, what about preoperative preparation? Do you give them sulfa and kanamycin? There's a big to-do about that, pro and con. Charles?
Well, like everybody else, we're confused by the whole thing. I think the most important thing is good mechanical cleansing preoperatively.
Well, I think we all agree with that. The only trouble is trying to get it. When you have a good nursing service and they have cathartics and clear liquid diet and irrigations twice a day, and still you get in there and there's more stool than you want. I agree with that, but I use them because you can't depend on 100% clean out. What about you, Guy? Do you use them?
Yes, I use them routinely. However, I'm very much interested in something that I'd like to mention here that Charlie Ripstein mentioned.
Yeah.
1% recurrence rate. I have a higher rate than that, suture line recurrence and low anterior resection. 13% suture line recurrence, and I'm wondering whether we can't attribute this to strenuous antibiotic prep preoperatively.
No, you can attribute that because you don't take enough peritoneum out. You go down and watch Charlie. He doesn't have any left. You can't make that pelvic floor. And while we're on that business about recurrence because of the pre-op prep, that work was done by Vink in Leiden, Holland. I went over and visited him there. But that was all done on rabbits. You can't get the cecum cleared out of rabbits. You can't get the stool out, and it wasn't standard. What do you think of that, Charlie? You think that's going to contribute to recurrence because they had kanamycin?
I just don't know. I'm not convinced, John. I think it's a suggestion, but again, you can't apply it to humans.
Bill, do you have any thoughts about recurrence because of kanamycin or sulfa preparation in the bowel?
I don't know either. I doubt it, however. We use the preoperative preparation with antibiotics, and I think it helps a great deal in clearing the bowel out and help the mechanical cleansing. I mean, getting an empty bowel. I think it's very important that the patients not only have a clear liquid diet, but be sure that the nurses and nurses' aides understand that clear liquids means that they should have no milk. I think it's very important.
Say, Charlie, this might be a good time for your song and dance on the total colectomy business.
This actually doesn't refer specifically to this area of the colon, but it's just...
No, but for a carcinoma of the rectus sigmoid, are you not doing a total colectomy?
In very carefully selected cases, this is in line with the thesis that carcinoma of the colon is an organ lesion and that the incidence of second primaries is much higher than we're inclined to believe. And because this has been one of the best areas of cancer surgery, I think we're all inclined to be a little bit complacent about it and feel that we're doing well enough, but we're not. Quite obviously, we should be looking for ways to improve our percentage of permanent cures. And I think the first paper that really made me sit up and think about this was one by Mayo and Schlicke. Well, I think it was published about 1942, in which they studied a group of patients who had died within a short time of their original surgery, either in hospital or after leaving hospital, but within a period of about 6 months from the time of the original operation. And they reported that there was a second carcinoma unrecognized at surgery but found at autopsy in about 7% of their patients. And it made me feel that if the surgeons at the Mayo Clinic could miss that many lesions, small carcinomas, at the time of resecting, that it really must be much more frequent than people were accustomed to believing. And that many of the patients who came back and died later of metastatic disease 2 years later might be suffering from the effects of a carcinoma that was left at the time of the original surgery. So we undertook to study a group of patients by removing the entire colon and doing an iliorectal high rectum anastomosis to find out two things. First of all, whether this did produce a serious and intractable diarrhea, and secondly, to determine what the incidence of second carcinomas was in the specimen that were not recognized at surgery. Well, in 100 cases, we found 8 second carcinomas, and 5 of them were not palpable at operation. They were superficial lesions. Now, granted, these lesions may have taken several years to manifest themselves clinically, but they were there at the time of the original resection. So we then did a retrospective study on patients who had survived resection of a lesion for carcinoma of the colon by 5 years or more. And to our surprise, the incidence of second carcinomas in this group, either manifested clinically or picked up at autopsy, turned out not to be the usual 3 to 5% reported in the literature, but 15%. So that theoretically then, from this, we could expect to achieve about a 4 or 5% improvement on our results immediately, and possibly up as high as 15% in those patients who didn't develop metastatic lesions from the original tumor. So about 10 years ago, we started to select patients for subtotal colectomy. First of all, they were all in a group where we might anticipate that 10 or 15 or 20 years of life expectancy remained to them, and we were interested in keeping them well for this time. And obviously this ruled out the 85-year-old patient, and it ruled out people with heart disease, kidney disease, severe pulmonary disease, and so forth. And we also, of course, ruled out those patients who had extensive lymph node involvement or liver metastases or peritoneal seeding, and selected patients up to the 6th decade, not beyond that, who were healthy in other respects and who had a lesion that we thought we could cure.
Has it increased your morbidity or mortality?
No, actually our mortality has been less.
Of course, it's a selected group.
It's a selected group, but even so, I'm quite convinced now that anastomosing ileum to colon at any level, whether a right hemicolectomy or down to the upper rectum, is a much better anastomosis, a lower incidence of leakage, no obstruction because the contents are liquid. And I'm sure you've all observed that your right hemicolectomies, as a rule, have a much easier and smoother postoperative course with fewer complications than do colon-to-colon anastomosis.
You do an end-to-side down there?
We do an end-to-end, but with the Poth modification of carrying it out along the anti-mesenteric border so it becomes like an end-to-side. It's very simple to do. The interesting thing is that if you preserve the terminal ileum as close to the ileocecal valve as you can, and never more than about 3 or 4 inches, these people do not have permanent diarrhea.
How many stools a day?
Well, they'll start out by having, maybe 8 to 10 to 12. Within a couple of weeks, they're down to 4 or 5, and within about 6 months, they may even be constipated. It certainly hasn't produced a permanent frequency of bowel movements in any patient, so that even the morbidity has not been anything troublesome. The mortality has been under 1%, but of course this is to be expected in this group of patients. And in our first follow-up of 100 cases that have been observed for 5 years, we've had an 83% survival. Now, even admitting that these are favorable cases, I think the average in the literature on this type of case has been in the neighborhood of 70 to 75%. So that it's not enough to talk about statistically, but we're encouraged to continue this policy. And I think I showed you a case when you were in New York last time that we had picked up a small adenocarcinoma of the cecum in a young patient in his early 50s who came in with a carcinoma in the sigmoid, which was unsuspected radiologically and which we couldn't even feel at surgery.
I recall it was quite a demonstration for the Australians that were there, and it did help your thesis. But there's something against your thesis, which I'll mention here. Bill, 2 months ago you were in London and you heard Charles' good friend Bill Hughes of Melbourne, Australia, report 100% follow-up of 1,500 cases of carcinoma of the bowel, 100% follow-up, and he only had 1 or 2 cases that developed another carcinoma of the colon within 5 years. Now, who do you support, Hughes or Ripstein?
Well, I will not commit myself at this particular point because Charlie's a good friend of mine. But
it's all right, Bill.
In going over our own series, I followed his rationale to his logical conclusion. When I would do abdominal perineals, I would be doing a total colectomy and an ileostomy, because in my own cases, I've had as many new carcinomas develop in the patients I'd done abdominal perineals in as I did to those who had low anteriors. So it makes me wonder.
Well, it's certainly something interesting to follow up. Have you published that?
Yes, I presented this material before the American Proctological Society in Cleveland. It was published in Diseases of the Colon and Rectum.
About 3 years ago. Yeah. Okay, Charlie. A guy, you're getting restless there. What about a combined abdominal perineal resection? Do you do a 1-team or a 2-team, or how do you do them?
We've tried the 2-team. There's no particular advantage to that. I think you can circumvent all the time saving that everybody talks about in doing the 2-team by putting the patient up directly in lithotomy position or a modified lithotomy position before you do the abdominal part. And it's no problem at all.
But you do put the patient up in stirrups.
Yes.
Bill, what about you?
We do not use a 2-team, largely because of a health problem. However, I do think it has a definite place, particularly in some of the large lesions where there's a problem in finding a line of cleavage from above. I think where you have someone working from below, simultaneously, that you can find a line of cleavage a bit easier. So I think that there's a definite place for it.
I think there is too, and it is a manpower problem, and it's difficult to get 2 teams, especially another surgeon that is as good as you are. But it does have advantages, I think, having the patient up like that you can, even if you can't have 2 teams, work above and below at the same time. We delude ourselves in trying to think that you have a sterile field below and a sterile field above. And I too felt like Guy that there's enough commotion in the operating room with 1 team, let alone have 2. But I went to Toronto and saw Tovey do one of these, and it went so slick that I couldn't wait to get home and do one.
I think, John, one point, too, that Guy alluded to, it's a great help to have your second assistant down below. He can retract bladder or uterus and really help you considerably.
Yes, if you're doing a hand hysterectomy en bloc, it makes it much easier this way. And if you have a good resident, then he can help a lot. But it is difficult to get 2 teams. Everybody's so busy. Now, while we're on a combined, Guy, do you sew up the posterior wound primarily, or do you pack it?
No, I still pack it.
Well, you're getting old. Who closes it up? Charlie, you close them?
We do by choice. There are occasions when we have to pack it because bleeding mostly, but procedure choice is to close it and to use catheter suction drainage.
Yes, he's got all the right answers on this. He was wrong on some of those others beforehand, but I agree with him here that the vast majority that you can suture up. Don't you agree, Bill? Let me change that question. Don't you think that guys should start closing some of those up instead of packing them all?
Well, I'm old-fashioned also.
You pack them all?
Most of them. I'm probably kidding myself again, but I feel that with the pack, I'm very careful to put the pack in as deep as I can and try to get up behind the bladder so I can elevate the bladder. And by leaving it in, I think that I can help to...
How long do you leave it in?
About 6 days before I start loosening it.
What's it smell like at the end of that time?
Well, I use some of that stuff that you use to keep it from smelling.
Yeah. Well, I think you're wrong. If you look in there a day or two after you take that pack out, you'll see the bladder's right down and the peritoneum is down there. To me, they heal up much faster. You don't have a big loss of protein, and the patient is out of the hospital in 10 days. Now, I used to pack them too, the way I was taught, but the only ones I pack now are the ones that do bleed, or ooze that you can't quite control. But there, as Charles does, I put the catheters up above and put the kanamycin in every day. And I take the pack out in 36 hours, and then about 2 or 3 days later, close it secondarily. But I did used to pack them, and then I started suturing them up with a couple of Penrose drains. But even there, you get drainage for a long time along that sinus tract, so then I closed them up tightly without any drainage. And that worked fine in about 80% of the cases, but about 20% would develop an abscess. And as you know, some of these abscesses will develop several weeks later. So now I close them up. It's a hemovac drain. I usually put the 2 in. Some people put them from above. put it on suction, and then every 4 hours I put in 50 cc of a 1% kanamycin solution. And they've all healed up primarily, except a few cases of ulcerative colitis. But even with ulcerative colitis, they will heal up, most of them primarily, and the patient's out of the hospital. The convalescence is much smoother. And the ones that do pack, take it out in 36 hours, and there isn't any smell if you do use that kanamycin or some antibiotic up there.
May I say a word about packing? There are two ways of doing this, and I still have my patients discharged 10, 11 days after the operation. I believe it does support the bladder, and I don't believe that it has anything to do with the morbidity.
How long does it take them to heal in, Guy?
Oh, it may take a month or two, but they're perfectly comfortable. It will take a long time. I just worry about drains placed like this. Don't you get little sinuses and tracts and so on after the black?
I've never had a sinus along through there. Some of them have drained through the suture wound in ulcerative colitis. Well, you try it sometime. Now, what about the ovaries? Gilbertson at the University of Minnesota showed that the recurrences that would occur were in an anterior-posterior line of cleavage. You can only go so wide, and his thesis was that we were not going far enough anteriorly, and they did occur, this is from the University of Minnesota, along the posterior vaginal wall and in the posterior cul-de-sac and in the ovary. As you know, Moss Stearns and his group at Memorial Hospital found an 18% incidence of ovarian involvement in a Duke C. Charles, you take the ovaries out of these patients?
Yes, routinely.
Guy?
I certainly do whenever it's feasible, and when I can add that to the operations. That doesn't lengthen it very long, but I don't do it routinely.
Bill, you trained as a gynecologist for a while. Probably takes you 2 hours to get that ovary out. Do you take them out?
I do.
Well, that settles that. Now, who does a panhysterectomy en bloc if the thing is right down near the back of the cervix? Charles?
Well, if the lesion's on the anterior wall, I think hysterectomy is a very excellent idea. And certainly if there's any excuse for it, like a fibroid uterus, we do it routinely. But the uterus does have one useful function in that it does provide some support, prevents the bladder from dropping back, so that I think you have to weigh this carefully.
Well, you're a little bit inconsistent here. Here you're scraping away all the peritoneum on the man, but you're letting the uterus stay in there.
No, I quite agree with you that for a good cancer operation, especially with an anterior tumor, that the uterus should be taken out too.
And what about the posterior vaginal wall? You usually take that out?
Well, the husbands might object, John.
Well, I won't say anything. What about the lateral gutter? You close the lateral gutter in a combine?
No, I do not.
Guy?
I do not.
Bill?
I do not.
Neither do I. That's the first time I ever saw that. I used to, but I had 2 obstructions, and they're both ones that I closed, and I closed them myself. I don't do it anymore. One thing I do that's a little different, I make a right rectus incision for a combined instead of a left rectus, and then bring the colostomy out a little more medial than it usually is, about through the belly of the left rectus muscle where Rube Turnbull said it should come out. Now that brings up a point about where it should be. Whereabouts do you put the colostomy, Charles?
I've been doing practically all of the abdominal surgery in recent years through a midline incision, going right through the umbilicus, not around it, but right through it, and you can extend it from the symphysis pubis to the xiphoid if you want to or need to, and we close it with 1 layer of steel wire, figure-of-8 sutures. We've been tremendously pleased with this incision and the good wound healing. I was brought up to believe that the umbilicus was a terrible place, that we should steer clear of it. Dr. Mark Moses of the University of Tel Aviv suggested that no harm comes from going right through it, and we've been doing this routinely, and I demonstrated it to you on a few cases, if you remember.
Yes.
Those wounds heal up beautifully. It's fast getting in, it's fast closing, and then that leaves you both sides of the abdomen if you want for colostomy or ileostomy or any such thing.
You do agree that it's well to have the incision away from the colostomy site, do you not?
Yes, I do. I don't know whether this is rational or not, but I never like to bring a colostomy up through a wound.
Well, that's another question. Bill, do you bring it up through the wound?
I do.
Guy?
I used to, but not anymore.
Well, I used to too, and I don't like it. You get little hernias there, and I never had one eviscerate, but it would be a messy thing if it did. Why do you bring it up through there, Bill?
Use a left paramedian incision through the fascia, then dissect the fascia over and go through the midline between the rectus into the perineal cavity. Then I bring the colostomy through the rectus, the left edge of the rectus, and then through the incision. And it's worked that way very well, and I've been satisfied with it, no reason to change.
Well, you try it. You put the incision on the right and try it through a stab wound. I was amazed in a panel in San Francisco that Moss Stearns and the group at Memorial Hospital still bring it up this old-fashioned way. You try it the other way.
John, I think you ought to emphasize it by stab wound. You don't really mean that.
Oh, no. You take out a wafer of skin, and Rube Turnbull says you don't have to take out a wafer of fascia, but I usually take some out. I find that it does get a little tight in there. Have you found that, Charles?
I just do a cruciate incision in the fascia.
But I think you want it big enough so you get about 3 fingers through there, unless it's obese bowel. Norm Nigro brings them right out through the umbilicus. I've never done that.
No.
Now, when do you decide exactly where you're going to put that colostomy, Bill? At the time of operation or what?
Before we start the operation, depending upon the type of abdomen through which we're working.
Well, do you mark the abdomen where you're going to bring it out?
That's right.
When? Right on the operating table?
That's right.
That's wrong.
That's wrong. You got to do it the night before, and you got to have the patient standing or sitting, because otherwise you'll find the colostomy on the lower part of a pendulous abdomen, and it's awfully difficult.
Right.
I have to defend myself a little bit here.
A lot.
I must say that I have a very good idea beforehand, because when we've examined these patients in the office, when he comes in with these clothes on and the like of that, so that we have, while we don't market it to that time, we know pretty much where we're going to put that colostomy before the operating room, but we don't mark it until we're in surgery.
Okay, Bill. Now, you've just transected a ureter, the level of the pelvic brim, maybe a little bit lower. What are you going to do?
At that particular level, we would anastomose the cut end over a small T-tube, about an 8 to a 10 French catheter, and bring that through a stab wound in the left lower quadrant.
Do you bring the T-tube through the line of suture in the ureter? Or do you make a stab wound above and put it down?
I thread either end after I have sutured the posterior wall. Slide the T-tube in.
Charles, do you put a T-tube in those?
No, we usually make an oblique suture line and drain it without a tube or without any kind of splint.
That's what I do in all the ureters that I cut. Guy?
We used to put a little tube in and put it down the bladder, call a urologist, and have him go up with a cystoscope and take care of that ureteral catheter. I think that works very well, but I believe you just sew it together and drain the general area, you're all right.
Yeah, I'd hesitate to have those fellows go poking a catheter up through there. Now, suppose the cut's a little lower, Bill. What are you going to do then?
Way low, undoubtedly would need to transplant the ureter into the dome of the bladder.
What about into the other ureter? John Madden had an article on that a couple years ago. Transplanting one ureter into the other.
That I have never done.
Yeah, we've done that. This is an excellent procedure.
It's easy to do, too.
It's easy to do, and it's a very, very good operation. It works well. I think it's much better than trying to transplant it into the dome of the bladder.
That's always a problem, it seems.
Yeah.
What about cutaneous ureterostomy?
Well, I think occasionally in a patient in bad condition, this may be the choice, and you also have to consider the possibility of whether or not you might do a nephrectomy.
Well, what about just tying that ureter off at the time?
This you can do too, and the vast majority of cases, a kidney will atrophy without any problem, but occasionally you will get an infected pyonephrosis and have to remove the kidney.
Yes, the first time I saw a ureter tied off like that was by the late John Waugh, and I did shudder. But it can be the procedure of choice in some patients. You get a routine IVP in all patients?
Yes, I'm not so much interested in that side, but usually the left, but in knowing that there's a functioning kidney on the other side, because this is going to influence my choice of procedure.
And also that there isn't an ectopic one in the pelvis.
When I was a resident, I divided a last adhesion in mobilizing the left colon one day, and it had a lumen and it didn't bleed. So we figured it had to be the ureter, and it was. But the carcinoma had been in the region of the splenic flexure, and although it had peeled easily off the capsule of the kidney, we decided that this was an old patient, that the quickest way out of it would be to just remove the kidney. And when the pathologist examined the specimen, there were tumor cells in the capsule of the kidney. And that patient has lived for about 15 years and then died of other causes. So this was one case where it was lucky to be dumb.
One other thing, to avoid injury to the ureter, of course, if you anticipate trouble, you have somebody put catheters up ahead of time, but as you know, your experience is when they're there, you don't need them, and it's when you didn't expect you'd need them that you wish they were there. And this is something you can do. Just mobilize the ureter, bring it up under a little tension, make a slit, and put the catheter down right then and there, and leave it there. And then at the completion of the operation, put one fine catgut, plain catgut suture in it, then withdraw the catheter, tie it, and a little Penrose drain down to the region. I've done it many, many times, and it's always when you don't anticipate trouble that you need them. So that's one trick. One question from the audience. Wanted to poll the panel here about the ligation of the internal iliacs. Lawrence Abel in London has been doing it for 30 years routinely, and always combines routinely ligating the internal iliacs, and he told me he's never seen a sloughed bladder nor a sloughed penis, but he does it routinely. Charles, do you do it routinely?
No, I don't do it routinely. First of all, it's rarely necessary, and you're dealing with an age group that usually have peripheral arteriosclerosis. You might cut off some awfully valuable collateral circulation to the extremities, so I would feel it's contraindicated unless
you can
it's
see
necessary.
where it might be helpful in the large tumor control.
No, I don't think it would be.
Guy?
It can be used, but I don't use it routinely. I understand that a study has been done at Temple University where they just saved 200 cc of blood. I didn't think that was significant enough to do that in every case then.
Well, it seems to me that would be a very difficult controlled study on that. Bill?
I do not do it routinely, but I have used it where we have gotten into considerable pelvic bleeding, and I have had no difficulty afterwards.
I've done it too, and especially in doing a panhysterectomy in a large lesion with an end-block excision. It has been quite helpful.
Thank you, gentlemen. And this concludes another edition of Audio Digest Surgery, produced and copyrighted twice each month, along with 7 other programs in tape-recorded postgraduate medical education by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association.